So thank you for coming today. On behalf of the American College of Veterinary Pharmacists, I'd like to welcome you all to our second in a series of town halls. I'm Gigi Davidson, and I'll be moderating today's session, during which we will be discussing FDA's guidance for industry number 256, which is entitled Compounding Animal Drugs from Bulk Drug Substances. This guidance was implemented on April 1st of this year, and it's already created quite a ripple in the veterinary compounding community. In fact, its impact may not be limited to just veterinary compounding. I heard just this morning that some state boards are considering adopting elements in the guidance that would be similarly enforceable for human compounding, so we should all stay tuned on that. Our format today is to have a summary presentation of the guidance, followed by a question and answer session hosted by expert panelists. We ask that you please save your questions for the Q&A session in the interest of time. And when we begin that, we ask that you can submit your questions on the Q&A dashboard in Zoom. We apologize for the inconvenience of that, but we have about 170 participants, and that's too many to manage the chat room or hand raising. So thank you for working with us on that. And I also wanted you to know that there will be a recording of this town hall on the ACVP website next week at www.vetmeds.org. Our speaker today is Brenda Jensen. Brenda owns Compounding Consultants, LLC in Sioux Falls, South Dakota. She's helped hundreds of compounding facilities across the country improve compounding quality and safety. Brenda is currently the president-elect of the American College of Veterinary Pharmacists and serves on the board of directors for the American College of Apothecaries Research and Education Foundation. Brenda is a peer reviewer for the Pharmacy Technician's Letter, is an ACVP delegate to the APHA House of Delegates, and also teaches compounding courses for the American College of Apothecaries. She was previously the coordinator for the APHA Compounding Special Interest Group and served on the board of directors for the International Academy of Compounding Pharmacists, now APC, and the Pharmacy Compounding Foundation. Brenda began volunteering for USP in 2013 and is currently chair of the 2020 through 2025 Compounding Expert Committee. Brenda, thank you for speaking for us today. We will go ahead and start the presentation, and then when we begin the Q&A session, the panelists can introduce themselves. Thanks, Brenda.
Thanks, Gigi. Welcome, everyone. Thanks for being here today. Oops. Okay, this is the guidance document that we're going to talk about today, so you can see what it looks like from the cover. We'll start with a little background. Most of us are familiar with FDAMA, the Food and Drug Administration Modernization Act of 1997, that tells us when we can compound using bulk drug substances for humans. What we have on the animal side of things is AMDUCA, the Animal Medicinal Drug Use Clarification Act of 1994. You can find this in 21 CFR Part 530. Both FDAMA and AMDUCA are amendments to the Federal Food and Drug Cosmetic Act. In AMDUCA Part 530.13, titled Extra Label Use from Compounding of Approved New Animal and Approved Human Drugs, it says, this part applies to compounding of a product from approved animal or human drugs by a veterinarian or a pharmacist on the order of a veterinarian within the practice of veterinary medicine. It goes on to say, nothing in this part shall be construed as permitting compounding from bulk drugs. FDA has admitted that there are times when compounding from bulk drug substances is necessary. In 1996, a compliance policy guide was published that stated when FDA would use discretionary enforcement, which basically means if you play by their rules, they won't hold you non-compliant to certain aspects of federal law regarding new drug approval, instructions for use, or CGMP. The CPG was revoked in 2015 when GFI number 230 was published. GFI number 230 was revoked in 2017, leaving us without any guidance until GFI 256, which will be the focus of our town hall today. GFI 256 limits the use of animal drugs compounded from bulk drug substances to when there is no medically appropriate human or animal drug that is FDA approved, conditionally approved, or indexed. Conditional approval allows the sponsor to make a drug available before collecting all the effectiveness data. There are limits to when this may be done. Index drugs are legally marketed, unapproved new animal drugs intended for minor species. FDA intends to focus enforcement activities on those activities that present the most significant concerns, including activities that present particular human or animal safety concerns, such as when a drug is super potent or has microbial contamination. Activities that are intended for use in food-producing animals. FDA is concerned with harmful residues in our food supply. Those that are copies of FDA-approved or indexed drugs, or those that are sold as office stock. GFI 256 explains circumstances where FDA does not generally intend to take enforcement action for violations to federal requirements. These fall into three categories: compounding for non-food producing animals with patient-specific prescriptions, compounding for non-producing animals without patient-specific prescriptions, and drugs for use as antidotes for food-producing animals or sedatives and anesthetics for free-ranging wildlife species. We'll discuss the details of each of these. There are some requirements that appear in all three of these areas. These include compounding by or under the direct supervision of a veterinarian or pharmacist in a state licensed pharmacy or federal facility, compounding in compliance with state laws and regulations governing drugs, pharmacy, and veterinary medicine, having a valid veterinary client-patient relationship, and bulk drug substances, inactive ingredients, and finished drug products used in compounding meet the standards set in any applicable USP/NF monograph and comply with other FD&C Act requirements for drug components. Let's take a look at what the FD&C Act says under FDAMA about drug components. They need to comply with standards of an applicable USP or NF monograph if one exists, and the USP chapter on pharmacy compounding, so 795 and 797. If there is no monograph, the bulk drug substance is a component of an approved drug or appears on the bulks list. Suppliers must be FDA registered, and the bulk drug substance must be accompanied by a valid certificate of analysis. FDA didn't say exactly which parts of this they were going to enforce, because it goes on to say we can't use anything on the negative list, which we commonly do in animals. We can't compound regularly or in inordinate quantities anything that is essentially a copy of a commercial drug. We know from another guidance document that FDA defines this as more than 4 times a month. We also know copies are permitted if they produce a significant difference for a specific patient, as determined by the prescribing practitioner. And finally, we can't compound anything that has been determined to be demonstrably difficult. Okay, so when we look at each of the specific areas mentioned by FDA, each has additional criteria. Starting with compounding for non-producing animals with patient-specific prescriptions. If compounded by the pharmacy, it must be dispensed after receipt of a prescription for a specific patient directly to the prescribing veterinarian or to the patient's owner or caretaker. Or if compounded by the veterinarian, it must be dispensed to the owner or caretaker of a patient in his or her practice, or to another veterinarian in his or her practice located in the same physical location. Compounded drugs can't be dispensed or transferred to a third party or by a pharmacy to a veterinarian who did not write the prescription. The drug can't be a copy of an FDA approved or indexed drug unless it will produce a clinical difference in that particular patient as determined by the veterinarian. FDA defines a copy as having the same active ingredient or active moiety and the same route of administration. If it is a copy, documentation is required. The pharmacy needs to retain a copy of the prescription on which the veterinarian has noted the medical rationale, or they need to contact the veterinarian to obtain the medical rationale and note it on the prescription. If it is compounded by the veterinarian, the medical rationale should be noted in the patient's medical record. Let's look at some acceptable medical rationales. Allergies or toxicities, or the commercial dose is not appropriate because it is too small or too large, or the patient cannot safely be pilled with the approved tablet or capsule. Those would be all acceptable examples. Some reasons that would not be acceptable include price, patient or prescriber preference, or the patient needs a strength that can be easily dosed from the commercial product. The veterinarian needs to determine the medical rationale for compounding, something that is essentially a copy of a commercial drug. The compounder needs to document why an approved drug can't be used as the source of the active ingredient. Some acceptable reasons include properties of the drug. For example, you wouldn't crush a tablet to make an injection. A component in the commercial drug might be toxic to the target species. And a big one for pharmacies, the FDA approved or indexed drug that contains the active moiety is not available for compounding. The next area is compounding for non-food producing animals without patient-specific prescriptions. The veterinarian who stocks the drug dispenses or transfers it only to the owner or caretaker of the animal patient or to another veterinarian in the same practice. Drugs can't be dispensed or transferred to a third party, including to a veterinarian at another physical location. The drug must be intended for use in non-food producing animals, and it must be on FDA's list. Okay. Here's a look at the list for dogs, cats, and horses. You can see there's specific drugs, dosage forms, and strengths on the list. It continues here. And then there's a list for the non-food producing minor species. Keep an eye on these lists, they change periodically. You can also find a link to drugs that were evaluated but did not get added to the list. In that same area in the guidance document, you can find how to submit drugs for consideration to the list as well. Our last area of discussion is antidotes for food-producing animals or sedatives and anesthetics for free-ranging wildlife species. The veterinarian, in addition to everything we've discussed previously, the veterinarian must document withdrawal time and ensure residues are not present at the time of harvest. Okay, there's a specific list for this as well. Okay, and this list is much shorter. Next, we need to take a look at labeling requirements. Of course, we need to follow the normal state and federal law requirements, many of which are listed here, but FDA has several additional labeling requirements as well. They say you must report suspected adverse reactions to the pharmacy and to FDA using online form FDA 1932A. So this is part of the labeling. Another part of the labeling is to say this is a compounded drug, not an FDA approved or indexed drug. And then also caution, federal law restricts this drug to the use by or on the order of a licensed veterinarian. If it is a patient-specific prescription, of course, we're going to need the name of the patient and veterinarian. For office stock, in addition to the veterinarian's name, there's a requirement for the address and contact information, as well as labeling that states not for use in food-producing animals. Okay, this is in addition to other extra labeling requirements that we just discussed. The veterinarian's name, address, and contact information is also required for the food-producing animals, or if a wildlife species, the wildlife professional's information is required, as well as the withdrawal time. Lastly, in order for FDA to determine if the compounded drug presents particular human or safety concerns, there's a requirement to report adverse reactions or other issues to them. And this is done on an online form and needs to be done within 15 business days. Okay, we went through that pretty fast. I'm going to turn it over to Gigi, and we have plenty of time for our discussion.
Okay, thank you so much, Brenda. That was a really good, clear-cut explanation of where the boundaries are and what the expectations are for the compounding community. So I cannot see the Q&A platform. I did have a couple of questions sent ahead of time while Terry and Linda managed the Q&A box. Before we do that, I would like for the special group of panelists that we have to introduce themselves. You guys have already met Brenda and heard her introduction. We also have Dr. Rob Hunter as a panelist. Rob, would you tell us a little bit about yourself?
Thank you, Gigi. Brenda, I have to agree, that was an excellent presentation. Thank you so much. I'm Rob Hunter. I'm a veterinary pharmacologist by training. I was invited to represent the animal health pharmaceutical industry. I also hold an adjunct faculty appointment to the University of Missouri, Kansas City School of Pharmacy, where I teach veterinary pharmacology and veterinary pharmacy.
Thank you, Dr. Hunter. And we also have Dr. Matt Martin. Matt, would you tell us about yourself?
Yeah, hi everyone. I'm Matt Martin. I serve as Director of Clinical Services at PCCA. I'm a pharmacist by training, been involved with compounding for the last 17 years, about half of that in practice and half of that at PCCA, with a focus on a number of different areas, but including the legislative and regulatory side of compounding.
Great, thanks, Matt. We also have Dr. Brian Bowers. Brian?
Hi, everybody. Thanks for the invite here. It's quite an opportunity to be here to speak today. And yeah, I'm Dr. Brian Bowers. I'm the Director of Pharmacy here at Oregon State University at the College of Veterinary Medicine.
Great. Thank you so much. And we also will have Dr. Natalie Young, who is in the middle of a State Board of Pharmacy inspection right now. So I've let her know that Brenda's presentation is finished and we'll be waiting for her. But let's just go ahead and get started with some of the questions. Brenda, you showed a copy of what we call the positive list on the screen in your presentation. And at the FDA website, there's also what's known as the negative list, and that's drugs that were reviewed but not placed on a list. And a lot of the same drugs are on both lists. Can you kind of explain the difference for our participants?
Is it the same drugs but different strengths or dosage forms?
Yes, yeah, I think that's what.
Yeah, I've had questions about whether people can change the strength of the drugs on that positive list, but I don't think that they're going to be able to. I think they're going to have to stick to those strengths that are listed.
That's my impression as well. And let's see what we got here. The questions are coming in now. Someone has asked regarding the labeling, do the statements have to be on the direct label, meaning on the immediate container, or can it be on a separate piece of paper given with the prescription?
That's a good question. The wording says labeling, and so by USP definition, that would be any kind of paperwork that accompanies the package. Now, whether FDA will enforce it that way or not remains to be seen.
It will, just because those same definitions exist within federal regulation.
Okay.
So that would be my understanding, but they didn't probably tell me. So I guess we'll wait and see what happens in some inspections.
Thank you, Matt. The next question is, can you please repeat what we need to do for dispensing office stock of compounded meds if we order them from an external pharmacy? I guess whoever wants to take that question. Brenda, you want to take a stab at that?
And so the veterinarian would need to document the medical rationale, or the pharmacy would need to call the veterinarian to find out the medical rationale. And then if it's from a bulk substance, the pharmacy would need to document why the commercial drug couldn't be used. And then on the slide, we have those potential reasons why or why not that would be acceptable.
And it's also apparent that the list of things that people currently stock for office stock is going to change radically. They will only be able to obtain compounds that are on the positive list for office stock. I'm going to pick on you a little bit now, Dr. Hunter. How is the lack of compounding guidance? We've been trying to get this right since 1996. How has the lack of compounding guidance for bulk drug substances affected the animal health industry to date? And what kind of impact do you think GFI 256 will have on the animal health industry?
I completely agree. From an industry perspective, the companies have been very frustrated with a lack of guidance. There's no question about that. The industry's biggest concern is, for lack of a better way to say it, the abuse of bulk compounding. Because the animal health pharmaceutical industry is such a small industry compared to the human health, we're less than 10% from a sales standpoint. There's significant concern about losing sales and appropriate use, and then getting products or actives misconstrued as being either a lack of efficacious or toxic because of inappropriate compounding. So we're hoping that this guidance will help bring some of that in. Our biggest concern is based on feedback we've heard from FDA and from industry representatives is a lack of enforcement. We're not expecting, from our perspective, things to really change because the agency makes this a low regulatory priority. So unless they hire a significant number of inspectors to do it, we really don't see much changing from an industry's enforcement perspective.
Thank you. And I wonder how much practicing veterinarians know about this guidance because they're the factor on the demand side of office stock compounds and compounds from bulk drug substances. How much do you think practicing veterinarians know about this guidance and how to comply with it?
Not as much as you folks do. To be quite honest, I haven't seen it as a broad topic from continuing education. I haven't seen anything really popping up. I could be completely wrong, but there certainly hasn't been any mass educational efforts made to educate veterinarians about this. I'd love to see that change because I think that's in everybody's best interest. The more we learn, the more appropriately it can be done, because there are certain very appropriate uses of bulk compounding and compounding in general. More education would be huge.
Great, I agree. Dr. Bowers, you work in a veterinary teaching hospital pharmacy and care for lots and lots and lots of different species of patients. Anticipatory compounding is not addressed in GFI 256. How do you think veterinary teaching hospital pharmacies are going to be able to keep adequate supplies of fast-moving compounds in inventory? Have you thought about that?
Yeah, a little bit. And, you know, I certainly have some concerns I feel for our compounding pharmacies. I know here, particularly at OSU, we have a very strong reliance on our compounding pharmacies. And thankfully for me here in Corvallis, Oregon, we have 2 compounding pharmacies that are local. And I know they're diligently trying to, you know, apply. And, you know, and I do get the sense that it is a little bit of a struggle. And, you know, and but yeah, and, you know, just thinking about the board of pharmacy too, like, to Rob's point, you know, like the lack of enforcement, and that I know our board of pharmacy is kind of out of the loop at this current point in time. But sure, I definitely have concerns on how we're going to keep up and anticipate moving forward.
And to kind of follow up on Dr. Hunter's comment about the education of veterinarians, has your pharmacy or have other veterinary teaching hospital pharmacies made veterinarians and student veterinarians aware of this guidance and how it's going to affect them?
Yeah, I'd say at best it's been pretty minimal at this point. The vast majority of them are completely unaware. And I've only had limited discussions myself with my team here on site. And it's usually just our small animal, like oncology or medicine units that have been affected by this already.
Okay, yeah, I get the comment. You pharmacists figure it out and just tell us what to do and we'll do it. That's the comment. Dr. Martin, you are, one of your many hats that you wear is working at a chemical supplier, a bulk drug substances supplier. What do you think the impact of this guidance will be on the supply of active pharmaceutical ingredients and bulk drug substances?
I don't know if this is going to affect whether or not APIs are available. I think when I look at this on the patient-specific side and how the drugs are compounded, I'm more interested in the quality of the compounded formulations that'll be produced. And this idea that everything should be compounded from a manufactured product, except in cases where you can show that it's not, is somewhat concerning to me. The idea that just because you make it from a manufactured product somehow makes the final compound a better preparation. I don't know if that's a model that we should be instituting, because there's multiple times that there's been evidence to the contrary of this. And I think we lose sight of the compounding process as well. So USP has some data that has been published on failed formulations, and some of those show specifically they failed because they were made from a manufactured product. And that's not to say the manufactured product was bad in any way. It's just that all of a sudden you include chemical entities in a formulation that would not normally be in there that may have an impact on that final formulation. I think at times compounders can also be more specific, utilizing the certificate of analysis of a chemical to calculate the specific amount of the ingredients. And we also have some struggles in using specifically the veterinary manufactured products, in that the excipients are not listed in the package insert for those products. So it's not possible to know what else is in there, or whether or not that could be problematic when it's used in a species that is not already indicated for that particular product. And in terms of the process, there was previously a particular 503B entity that touted very much that they only use FDA-approved products to make their compounded formulations. And that particular entity ended up being shut down by consent decree by the agency. And that was all a matter of the compounding process. And so sometimes when we get into doing these things where, especially at larger scales, the number of manipulations involved for a large number of vials may introduce more opportunity for contamination of sterile preparation. So I don't know that we can boil things down to, if we make stuff from manufactured products, we guarantee quality of the final compounded preparation. We've got to take a step back and consider how the excipients play a role in these compounded formulations, as well as the process by which those medications are produced.
Thank you, Matt. All really important aspects to consider in this enforcing this guidance and complying with it. I'm going to break from the questions just a second to let Dr. Natalie Young introduce herself. Thanks for joining us, Natalie.
Hey there. So I am Natalie Young. I am the current pharmacist in charge of Brava's East Coast operations. So Brava is specifically focused on small animal and some exotics. And we do all medications for those animals in clinical consults. But as we all know, our main job is getting the drugs into the animal. So that comes with a lot of compounding. And I also assist a lot with a large equine practice.
Great. Well, welcome. Thank you for joining us. Here's a question. I'm going to go back to Brenda as kind of a follow-up to some of the things Matt Martin was saying. Both FDAMA and this guidance call for compliance with USP monographs, but GFI 256 doesn't call for compliance with USP compounding chapters like FDAMA does. But if you look at FDA's checklist for pharmacists, it states meet USP standards and Food, Drug, and Cosmetic Act requirements. So as chair of the USP Compounding Expert Committee, do you think that this guidance is going to require pharmacies to comply with the compounding chapters?
Historically, they've been required to. Veterinary only pharmacies have been required to, so I don't see that changing. I think they're going to pull that part of it out of FDAMA. What worries me is the FDA negative list part, because those are drugs we're commonly using in animals. And so I think they're gonna cherry pick what they want, what they want to pull out of there as far as components are concerned. But it's hard to say.
It is hard to say. So I guess most states are going to regulate pharmacies as pharmacies and expect them to comply with USP compounding chapters within their states. Natalie, I know you've been working on this as a PIC for a long time, getting your pharmacy ready, and the veterinarians you work with, you collaborate with. What measures has your pharmacy specifically taken to comply with GFI 256?
Yeah, we've actually had a task force for our locations for over a year preparing for this. And in general, the biggest steps that we've taken, we have internal SOPs for addressing this, but really what this calls for is sending almost everything becoming patient specific, which in small animal practice, if that's your business model, which it was ours, it was not, it wasn't a big challenge until we started looking at there were a few preparations, then mainly the ones were the OTIC preparations. So that became more of a challenge, and it makes sense, right? Because if there was like a drug recall or something like that, we want to know what years those OTIC preparations went into. But it's also challenging for the veterinarians because sometimes you don't know that those bad ears are in the clinic until they're in the clinic in front of you. As someone with a massive golden retriever, once I get him to that clinic, please don't tell me that I need to put him back in the car and bring him back tomorrow for those OTIC preparations to be put in his ears. So that's been the most challenging thing, but they're doing it and they're compliant with it. Equine is a bit more challenging, and moving everything to patient specific there. And, again, just working through that. Another measure we've taken is once a week reviewing the list, because they are living and breathing and they change all of a sudden. April 24th, you get buprenorphine that popped up on there, so making sure that you're staying compliant, making sure that you are changing what you're doing internally in terms of your formulary to match those lists. And it's a heavy lift, especially when, we have a whole commercial team for Brava. And so making sure, making sure that they know what the current formulary is as well, and that they're educated. The biggest thing we've done internally, because we work hand in hand with community veterinarians, is we do a lot of education and we do a lot of clinical consults. We attend clinical rounds with them. So educating veterinarians has probably been the biggest lift. And we started this a year ago, and it was a lot of not listening. And now, oh my gosh, they don't know, like, you know, they don't care until it hits their practice, and then they want to know. So we've just been bombarded with questions as well. So long answer for your little question. So
it's a long subject for sure. I'm getting a lot of questions in the Q&A platform about the list and where veterinarians can obtain these positive and negative lists. We will put that on the webpage when we post this recording next week, the link to the guidance itself and the link to all of the positive list and negative list and the list of things that haven't even been reviewed yet. And so that way you can bookmark it and you can go check it every day, like Natalie has suggested you do, to just stay familiar, because it is a very, 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 all the lists are very dynamic. I can think of one, for example, that has not been reviewed yet, is methimazole transdermal gel. Clearly that cannot be made from tablets. There is a methimazole oral suspension on the positive list that you can make, but there's not the transdermal gel. And so, Matt, do you know, is that being discussed? I couldn't find it anywhere on any of the lists. Any ideas what we're going to do with that? Obviously we can compound it for individual patients now, but any thoughts on that?
No, I don't know that there's any other way to know more about what or when FDA will review any of these drugs or give us any specific timelines, despite conversations that we've gotten to have. Natalie and I are involved with the American Pharmacists Association, and that has opened up some opportunities to have some conversations with FDA as this guidance was coming forward. But in terms of sharing any potential timeline or when things will happen is not something that we're privy to.
Okay. Well, for those of you, we'll post all these links on the website next week, but you can also find the process for nominating drugs and dosage forms and strengths at those links. So if you go through the list and there's something that you like to use in your office that's not there, follow that process to try to get nominated to be reviewed by FDA. I'm getting a lot of questions in the Q&A about shortages. Who would like to tackle that? Specifically, pimabendin has been in short supply off and on for a lot of the time that it's been on the market, because it is such a widely used drug, and it's a chronically used drug, and pets that are on it cannot go without it. So who would like to comment on whether or not that would be permissible to compound? Natalie?
I was raising my hand. I want to go back to the methimazole transdermal a little bit too, but Matt and I, as he mentioned, so we are the two compounding chairs for APHA, and so we were really lucky to get several sit downs with FDA, and this was one of the main things that we brought up to them. And so they said that shortages will actually be handled in a different manner. So as soon as you become aware of a legitimate shortage, then you will, the email address, I can't remember it off the top of my head. It's on their website, and maybe we can post that as well. But as soon as you become aware of a shortage, you email them that shortage has occurred, and they will start the process. But as long as you are fully documenting that there is a shortage, then you're okay, and that will be handled in a different manner. But you need to, again, just like you're checking these lists all the time, you need to constantly be checking whether or not something is truly in shortage, or not, because the minute it's available, you cannot be compounding that. So.
And to follow up on that, there's another kind of shortage for people that are not veterinarians, and that is the ability to get veterinary only products, particularly the branded products. The animal health industry, for a lot of good reasons, has decided to not distribute those veterinary only drugs to anybody but veterinarians. I didn't see this specifically on Brenda's list, but would that be considered an acceptable justification for using a bulk drug substance? Is that I can't get enrofloxacin tablets, I can't get marbofloxacin tablets. Those are bad examples because we shouldn't be compounding fluoroquinolones, but you know, you get the gist. Rob, you want to comment about that? About whether you would, from your perspective, consider that acceptable?
Back to Natalie's point, if you can document that there's a legitimate shortage and you can't get a hold of it, and we need to take care of these animals, then I think that's an appropriate path forward. You just have to make the effort to document why you're doing it. I think that's all anybody would reasonably ask is, for lack of a cruder slang, it's a CYOB kind of moment. I mean, cover your backside on this stuff. And that's all I think even the industry would ask. If we can't supply it to you, the animals still need to be cared for. Just make sure it's appropriate. That's all we're asking.
Great. Any other comments on that?
I'll just add that that's specifically listed in the guidance, saying that that is an acceptable reason. And they do list pharmacies as not being able to get veterinary only drugs. So
good. So it is on the radar.
Hey, Gigi, I'm going to touch on that
Matt.
real quick in terms of the shortage part, because it's one thing that's not directly addressed in the guidance. There's just a mention that when there's a shortage, FDA will implement their process around the shortage. And I think they're in a little bit of a tough place in that they don't have the same types of processes set up for the animal drugs that they do for human drugs in terms of shortage reporting. So they don't have the same avenue for information to be able to list those drugs in shortage like they do on the human side. So I think, you know, my impression, again, is just my opinion, is that they want, you know, those patients to be taken care of, but at the same time, they don't have a process that fits neatly in a way that they can document it through the official channels about the shortage. So they also would benefit from everybody sharing potential shortage information with them so that they can look into that. And that's what Natalie was referencing in terms of them wanting an email of, hey, you know, we understand this to be a shortage. But they may have other ways to mitigate the shortage that may or may not be compounding necessarily, but I don't think they have that same flow of information. I know Rob may have more to share on that, but
no,
it's kind of part of the issue.
You're absolutely right. And it's been a frustration both for veterinarians and for the industry because there isn't that rapid update listserv that goes out every day about what's on shortage. I know there have been discussions about implementing something like that. I don't know where those discussions are at, but I think it would benefit. I'm completely supportive. That would be beneficial for everybody, both when something becomes shortage and then notification when it's no longer a shortage, which is what the human side does also. So I think that'd be a really good step forward.
Good. Getting some very specific questions now in the question room. What about the history of Amduca? There is a perception that it prohibits the use of bulk drug substances to compound for animals. And the questioner would like to know, how did this happen? How did it come around to disallowing bulk chemicals for animals? Amduca is the extra label drug use regulation, for those of you who don't know what it is. So would somebody like to comment on its relationship to bulk drug substances?
I can hypothesize an answer. I don't know if it's the actual answer or not. I'll be straight up with you. Considering the size of the animal health market, more than likely, I suspect that in the early 90s, when this was being put through, there was concern from the industry about compounding from bulk circumnavigating the approval process and reducing the likelihood of new products being approved, and then cutting into market share. When you look at the industry, and we know that 75% of the animal health pharmaceuticals that are on the market sell less than $1 million a year in annual sales, any pull of that away from it is going to drive those products off the market because there won't be enough market to sell to. So I suspect it was due strictly to market size, is what my suspicion is, with so many products having such small volume sales.
Mm-hmm. And any other comments?
And Gigi, I know you're a strong historian on this topic, so you may be just as well to address it than anybody here in the panel. But back in the 90s, if I recall correctly, there were actions being taken against pharmacies for compounding animal drugs, even from manufactured products, because they were being used in a way that they weren't described in the package insert and weren't indicated to be used in the first place. And so in some ways, Amduca was possibly considered helpful in that it provided a pathway to use those manufactured products in ways that they were not originally created to be used for animals. Now, in terms of whether or not that should remove everything from bulk actually being compounded, I think that's a different discussion that we should have too. And because that part in the underlying regulation says, well, nothing in there should constitute this to be permitting of compounding from bulk, but it was a law passed about manufactured products. So it's kind of awkward to me that in a law about manufactured products, we would also then somehow take some inference about what that means for bulk drug substances. And in more recent years, with 503A, the Drug Quality Security Act, creating specific criteria by which drugs can be compounded for people using bulk drug substances, it seems somewhat awkward to me to create a more onerous system for our animals than we would create for people. But it feels that way, looking at sometimes of some of the requirements and the pieces and the differences, including even differences of what's considered a copy between GFI 256 and the copies guidance for human compounding under 503A. So there's a broader discussion there, but that's my understanding of history. And Gigi, if you have more to elaborate, that'd be super helpful.
Well, those are all, without a doubt, driving factors for the legislation. One of the technicalities is that Amduca is about extra label drug use, and only manufactured products have labels. Bulk drug substances do not have labels. So that inherently put bulk drug substances out of bounds for Amduca because they don't have labels. So the regulations to enforce Amduca couldn't really make that direct link. And so that's why they put the little part in there that Brenda threw up on her slide about nothing in this part shall be construed as to permit compounding with bulk drug substances. So there's been this huge disconnect because of a technicality, and that's how this has evolved. And so it may take, and I say this carefully, separate legislation to deal with compounding with bulk drug substances for animals like we do have on the FDAMA side. But be careful what you wish for. I would much rather deal with a guidance than to see Congress, especially now, get a hold of this and try to turn it into a working regulation. I'm getting some more specific questions here. Brenda, could you clarify for patient-specific prescriptions, do veterinarians need to document their reasons for bulk use and their reasons for an essential copy on their end when they're writing patient-specific prescriptions?
So the veterinarian needs to document the medical rationale for using something that is compounded on the prescription. Whoever compounds it, they're going to document the reason why the commercial drug can't be the source of active ingredient.
Yeah. because the veterinarian's not likely to have that information.
Correct.
How it can possibly be prepared. The checklist, again, one of FDA's checklists for pharmacists asks the pharmacist as the very first step to confirm whether or not the patient is a non-food producing animal or a food producing animal. So I don't think the pharmacy public is real clear on what defines a food producing animal. Rob, can you help us figure out, whose responsibility is it to determine whether it's a food animal or not? And then, what kind of alternatives do you have?
I look at it from an MDUCA perspective, where MDUCA says that if it's a food producing animal, the veterinarian's writing out the script, and if it's going to be compounded, that lies on the veterinarian's responsibility to define this as a food animal, because MDUCA says they also have to include a withdrawal time on the label. Now, what I know of as a food animal, being a guy who grew up doing food animal production, drug development and everything, what's a food animal in the US is not necessarily a food animal in other countries. Now, that's one issue. Logically, in the US, we don't think of dogs, cats, and horses as being food animals. However, we do think of rabbits as being food animals. We're seeing a lot of backyard chicken production type stuff where they may or may not be eating. The responsibility is on the veterinarian, even though the animal is a pet and is likely not to be eaten. Legally, they're still required to demonstrate that something like a rabbit, that they were informed of a withdrawal time that the animal could not be eaten. So you do have to think of that as a food animal. To take it even farther, there are specific drugs that are not allowed for use in an extra labeled manner in food animals. You mentioned earlier the fluoroquinolones. You shouldn't be compounding fluoroquinolones for bunny rabbits. They're food animals. That's specifically prohibited. So kind of keep those things in mind. And if you need to, check with the vet. It doesn't hurt for a quick phone call to call the vet and confirm, is this really a food animal if you don't recognize the species?
Yep. Any other comments on that? I know some folks are putting auxiliary labels on their dispensed medications, not for use in food producing animals. That CYOB that Rob was talking about. So this question specifically for Natalie, the questioner would like to know, is your pharmacy seeing more population prescriptions for zoos, rescues, barns, like herds and flocks of animals in lieu of this guidance?
No, we really haven't. What we are seeing is phone calls with our customer service team taking 45 minutes to gather all the patient specific information. But initially we thought we may see that, and we had we pulled out our deputy sheriff badges because we were like, well, this will not become a loophole. But we haven't. So
one of the listeners, a couple of the listeners want Rob to repeat what he said about fluoroquinolones and rabbits. You got somebody's attention.
Yeah,
there.
I was afraid. I've probably dug myself a really bad hole. But MDUCA states that fluoroquinolones are prohibited from extra label drug use. So anything outside the label in food producing animals. Rabbits are considered a food producing animal in the US, which means they should not be, if there isn't an approved product for rabbits, they shouldn't be used. That includes compounding for them. So enrofloxacin, marbofloxacin, orbifloxacin, any of those technically are in violation of federal law if they're dispensed for food animals, because they're prohibited in food animal use unless it's specifically on the label. And compounding is an extra label use, no matter how you slice it.
So Natalie talked a little bit about some of the OTIC preps and the need to have those, in the office. One of our participants has observed that some folks are now compounding combination OTIC preps, but they're using all commercial products to start with that complies with the letter of the law or the guidance in intent, but the listener would like some thoughts about the potential of harm to patients by doing it that way.
Me,
Natalie.
So this is happening not just from ODIC preparation. So several of the people on this panel I pinged maybe 2-3 weeks ago because caught wind of an equine veterinarian that was like, well, I'm going to start doing sterile compounding. So we started the discussion, and I'll let others pick up on that discussion. The ODIC preparations that you're doing in-house, I've seen these before, and I've seen these for years, and I want to caution you, if you don't understand compounding, and if you don't have a good understanding of the chemistry of mixing drugs together, don't do that, because I've seen those preparations, and I've actually seen cases where those preparations crystallized in a dog's ear and caused harm. So please don't do that without any supporting literature to what you're doing. Back to veterinarians trying to compound, and I will let the experts from USP speak on this, but it is my understanding that the new USP chapters apply to veterinary clinics as well. The other thing that I went so far to do was I went to my friends at the North Carolina Board of Pharmacy, and I asked them about compounding, specifically sterile compounding, and what they would think about a veterinarian doing that. And if you start to go down that path, then you're going to start to go down the path with boards of pharmacy as they catch wind of this, saying that you are now acting as a dispensing pharmacy, and they're going to come in and they're going to inspect you as a pharmacy. So be very, very careful before you go down that endeavor. But now I'll take my soapbox and I'll sit it over here and let someone else go.
I think that pretty well lets the audience know what this panel feels about throwing stuff together, just to stay on the technically correct side of the law. So there's another question here, and I'm going to throw it out to the group. I'm not sure. Updates on 503Bs that are providing office stock compounds to veterinary practices. What are your thoughts on that?
I think
it's happening.
Everybody's waiting to see how FDA evolves their opinion. You know, it seems that they have an interest in applying the guidance document to 503Bs, but there's some inherent challenges to trying to do that, both in the way that they wrote the guidance document and that 503Bs were born out of the idea of compounding for human drugs in the first place as a part of the Drug Quality Security Act. And it gets into then like, well, what list actually applies to the 503B outsourcing facility of what you can or can't use, depending on where they're supposed to look. So I think we will see something on this eventually, or that's the impression that we've gotten in our meetings with FDA through the American Pharmacists Association. But as far as them saying exactly how it's going to work or when they might implement it or when they might use it in their inspections of those facilities is TBD.
Another participant would like to know, and I think one of you already alluded to this, that Brian, I think it was, the veterinary products, you cannot find out what the inactives, it was Matt actually, because that's considered proprietary and it's not listed anywhere. And one of our participants wants to know, is there any way to get to that information? Excipients, flavors, dyes, all that stuff. Brian, have you ever had to do that in your practice? You've had an adverse drug reaction and you're trying to figure out what the heck is going on?
Yeah, we've had one instance where there was a veterinary product and we just had to call the drug company and just plead with them to say, hey, what did you put in this? And the client was super upset because they thought it was a full-blown allergy, but like we couldn't verify that.
Rob, do you have any comments? I mean, I understand why it needs to be proprietary, but do you think most companies are willing to share that information if there's harm or suffering involved?
In a one-off situation, yes. Will they share it in a broad public setting if it's not already part of a monograph? No. I know for certain compounds, I mean, the formulation, the PK is very formulation specific. So in those cases, small changes completely screw up the PK and absorption. So, and that's pretty common in a lot of the veterinary preps. That's one of the reasons we get a little uncomfortable with compounding, because we know the PK is going to change dramatically no matter what you do. So we're always hesitant to go down that path. And that's the other reason we don't put a lot of information we don't generate monographs for that reason. It's the Coca-Cola sauce in the product.
Yeah. And Rob, that's an excellent, going back, pulling my soapbox back about people compounding in-house if you don't know what you're doing. So speaking about pimobendin, if you just start doing that and you don't know what you're doing, you could be causing great harm to an animal that has been on a commercial product and they were controlled on a commercial product. And now you're compounding their pimobendin incorrectly. And now, you know, you could be drastically decreasing the amount of pimobendin that patient is receiving. So again, don't compound unless you know what you're doing and if you know the pharmacology behind the particular species that you're dealing with.
Thank you. Yes.
I think we should start wrapping it up here, but I'm seeing a few more questions that are still confused about what a positive list is, what a negative list is. Can we talk a little bit more about what the difference is and what the boundaries are? And I'm afraid that's going to have to be our last question for today.
Yeah. Brenda, you want to take it?
Yeah, I can take that. So on the guidance document, there's some links that go to the particular list. So for office use, there's a special list, and in the positive list, those are the things that are allowed for office use. There is also a list of things they evaluated and said no to. And so that's going to be the negative list. But you're only allowed to compound those things that are actually on the positive list. And then for the antidotes and wildlife species, there's a separate positive list for that. So they're specific to the type of compounding.
And in FDAMA, just a quick follow-up, if something is on a list to be reviewed, can it still be compounded until it's reviewed? Because I don't see a provision like that in the guidance, that it either is on positive, negative, or waiting to be reviewed. Yeah, and you can only work with a positive.
From the human side, yes. From the veterinary side, it doesn't look like it. So I would say no.
Okay.
There's a listing on the FDA website with the links for the positive and the negative and the yet to be reviewed list that says FDA does not intend to take actions for people making those things that are on the yet to be reviewed list. So there's that. And I guess the other thing I throw in about these lists are related to the office stock and or the antidotes specifically. Sometimes there's confusion about whether or not on the patient specific side, people have to go to look to these lists, and that is not the case. And so I want to make sure that we draw that line that patient specific is one thing, but these lists for office stock and antidotes are where you need to know about those lists as far as what is permissible. There's other things to do on the patient specific side, but it's not associated with these lists.
Yeah, that's a really good point and a major point of confusion for users, that the lists do not apply to patient specific prescriptions, period.
Yeah, and that's what, go ahead, Gigi, I'm sorry.
Now, Yeah, go ahead.
That's what I wanted to bring up about the methimazole transdermal. I would be shocked if I saw that going on the positive list, because, you know, when I think of office stock, I think of acute meds that we need to treat that patient right now. And then I think of chronic meds. So methimazole is a chronic med. So if I was a betting person, I would see that going to the negative list. So these lists do not, you still have to use your professional judgment as to what makes sense for a chronic med and should be used outpatient.
Okay, great. Well, thanks everyone. If we didn't get to your question, I apologize for that, but we encourage you to go to www.vetmeds.org next week and look for the posting of this recording and the associated links. We thank you for joining us today. We thank all our speakers and our panelists, and please stay tuned. We have another town hall coming up down the road, and watch for announcements regarding that. Thank you again, everyone. Bye.